Good day, everyone. This is Dr. Lahari, and today we are going to discuss the second part of miscellaneous disorders of the oral mucosa. The first part has already been uploaded last week, so this is the second and the concluding part to this two-part series topic. The learning outcomes would be explain the rationale of unclassified lesions of the oral cavity, describe the clinical pathological concept of geographic tongue and orofacial granulomatosis, identify clinical common entities like Fordyce's granules, sublingual varices, and lingual tonsil. Lastly, identify and describe endogenous and exogenous pigmented lesions of the oral mucosa. Now, what happened with this particular topic is that actually I've gone in the reverse order and I spoke of the pigmented lesions earlier in the previous class. So keeping to that, I'm just going to go in the reverse order and start off with point number 3. So let's look at some normal variants, or not to say they're not called lesions, but they are just variations that can be seen in the oral cavity. Fordyce's granules, sublingual varices, and lingual tonsil. We'll go through each one of these one by one. Fordyce's granules. Fordyce is the name of a person who's probably given the description of these granules. They are yellowish white, raised plaque-like, and they're actually developmental in origins and nothing but focal collection of sebaceous glands in the oral mucosa. They're often found bilaterally in the upper lip, cheeks, and anterior facial region. They lie superficially and consist of lobules and few ducts. So they're nothing but collection of sebaceous glands. The clinical implication would be actually no function at all with no pathologic changes. It is just seen as part of age changes in the elderly and should not be confused for any pathology. Sometimes these Fordyce's granules could give or mimic a lesion, and then the patient could be confused as to what it is. And if they do come to you with a suspicion, then it's very important that the doctor is able to clarify that these are actually normal variants. So this is an example of Fordyce's granules. As you can see in both the pictures, they are visible on the buccal mucosa, and they are yellowish, raised, and absolutely harmless. Moving on, the sublingual varices, also called as lingual varicosities. These are nothing but dilated, tortuous sublingual veins seen mainly in older men. Now, they are seen superficially, they lie superficially and raised, covering thin mucosa into soft, sessile nodular areas. You will understand this once you see the picture on the next slide. The formation of the varicosities in the vessels of the undersurface of the tongue and the floor of the mouth is a common finding with age. So as the patient ages, you will see that these sublingual veins become more and more prominent. Again, the clinical implication is not much. There are no symptoms at all, and then extremely rarely this could be a site for thrombus formation. But you must understand that it's because of these veins and prominent blood supply in the sublingual region that medication kept in the sublingual area is easily absorbed. So as you can see in this picture here, you can see very prominent veins, and sometimes young practitioners or young dental students who are early in their dental career can get confused and look at it as a pathology, but please be aware that this is nothing but a normal variant and prominent veins called as sublingual varices, or also called as lingual varicosities. Moving on. The lingual tonsil. Again, this is something which we've already covered when you were learning oral biology. They are a collection of lymphoid follicles covered by a thin lining mucosa. They're located on the surface of the posterior third of the tongue bilaterally. The clinical implication for this is that these tonsils are located in the posterior floor of the mouth, and the washing action of saliva provides effective cleansing. Hence, therefore, the tonsillar mass is rarely inflamed. So something which doesn't really cause much, is of less concern and doesn't really cause much concern. If you were to look at the groups of tonsils that are present in the posterior part of the oral cavity, you have the pharyngeal tonsil right on top, and then you have the palatine tonsil and lingual tonsil. So lingual tonsil is what we were just now talking about. Along with lingual tonsil, which you can see in this animated picture over here, the important thing which I've circled out is something which I would want to bring your attention to is the foliate papillae. Now, the scope of this class doesn't include discussing all the papillae of the tongue, but I specifically would want to bring your attention to the foliate papillae because there is a tendency for young dental practitioners to get confused for the foliate papillae, which are there at the lateral border, posterior lateral border, bilaterally on either side of the tongue. Erythematous slightly raised, and to get confused with the pathology. They are asymptomatic and nothing but papillae of the tongue and shouldn't be confused for a pathology. Right, so let's move on to a condition which is known as geographic tongue or benign migratory glossitis, and is also called as erythema migrans. Now, from the terminology, you might be confused of what are we talking about. I thought we were doing a class of oral medicine and oral pathology. Why are we talking about geography here? Well, this is nothing but constantly changing pattern of serpiginous white lines surrounding areas of red depapillated mucosa. Let me make it very simple. They're nothing but red depapillated areas on the tongue which have a smooth white border. I will show you in the upcoming slide. On occasions, this can be associated with psoriasis, and which has microscopic features similar to psoriasis. Psoriasis is a skin disorder, again, not in the scope of this topic. The clinical implication again for a geographic tongue is that majority of the time they go unnoticed. But at times it's important to understand that the patient might be concerned with aesthetics of the appearance of the tongue, or in rare occasions it could be symptomatic. And when symptomatic, the most common symptom that the patient would complain of would be burning sensation of the tongue and not able to tolerate very spicy or pungent foods. Now, various treatments have been tried for a geographic tongue, but none of them is actually very successful in treating the symptomatic cases. However, multivitamins, steroids, antifungals, antibiotics, and even topical zinc applications have been tried to treat symptomatic geographic tongue. But otherwise, on a normal patients who manifest with geographic tongue who are asymptomatic, it's absolutely normal. It's important to alleviate the fear that that is any lesion and make sure that the patient understands that the geographic tongue is actually absolutely benign and will probably change the pattern of appearance of these depapillated areas from time to time. That means the appearance of geographic tongue today may not be the same as it is appearing and might have slight variations in the red and the white areas a few days from now. So it's important to understand that the patient's fear is alleviated regarding this, and it's an absolutely benign condition. Doesn't require a biopsy, doesn't require any investigations. Moving on, I would want to bring your attention to a little more serious disease, which is the orofacial granulomatosis. Now, this is a term used to describe the common clinico-pathological manifestation of a variety of disorders. There is oral mucosal granulomatous inflammation without an identifiable cause. Now, it's not as commonly seen, and it is quite rare to find orofacial granulomatosis. The typical clinical features would be recurrent or persistent diffuse enlargement of lips and cheeks or diffuse facial swelling. Now, there is a larger component which will involve the rest of the body, but specifically, I will be talking to you about the orofacial aspect. The histopathology typically shows non-caseating granulomas and edema, and this is mainly seen in young adults. The clinical implications would be the possible causes behind orofacial granulomatosis, which can be anywhere from Crohn's disease, sarcoidosis, a foreign body or infections, allergic reactions, idiopathic causes, a Melkersson-Rosenthal syndrome. The chances of eventually developing Crohn's disease are higher if the patient actually manifests with orofacial granulomatosis and it is diagnosed in childhood. So the diagnosis of orofacial granulomatosis generally should be followed by a biopsy to confirm the presence of granulomatous um, lesions. So this is a clinical photograph of a patient with a swelling of the lower lip, which is definitely disproportionately appears swollen, and the other picture of a patient with the upper lip, which is swollen, and you can see that it is not very erythematous, but looks like normal vermilion border, but there is definitely a swelling and edema seen. This is the histopathology in low power and high power, which actually shows you dense inflammation and scarring extending deeply into the fat. And these changes are common to both Crohn's disease and orofacial granulomatosis. And that's why it makes it more difficult to differentiate the two by histopathology. The high power shows below the epithelium is a patchy, inflammatory, infiltrate, and scattered granulomas containing large multinucleate giant cells. So this is the difference between a caseating granuloma and a non-caseating granuloma. So you can see the difference in the structure here. The causes of orofacial granulomatosis is related to food allergy. The patient often have subclinical bowel disease, a higher than average risk of allergy to a range of common allergens, and react to common food additives such as cinnamon, benzoates and phenolic compounds. So it's very important when a patient who comes to you to get the gastrointestinal history or the gastric history, as well as abdominal symptoms that might present along with the orofacial symptoms. So it has been identified as both type 1 and type 4 allergic or hypersensitivity mechanism. The treatment is first of all taken by exclusion diet. Try to avoid allergens that food allergens that could be the cause, and nearly two-thirds of the patients have been known to respond to this exclusion diet. For the more serious cases, intralesional steroids, immunosuppressants such as tacrolimus or cyclosporin, methotrexate, or tumor necrosis factor alpha inhibitors like infliximab have been used depending on the severity. Of course, this treatment would have to be initiated by the physician. So just to summarize, the important granulomatous diseases are infections. Most of these have been covered in general pathology, but if you just look at them again, are infections like tuberculosis and atypical mycobacterial infections, systemic mycosis, cat scratch disease, toxoplasmosis, syphilis, reactive ones like foreign body reactions, and unknown causes like sarcoidosis, Crohn's disease, Melkers and Rosenthal, orofacial granulomatosis, and Wegener's. So let's now look at just two of these examples just to try and understand what the other manifestations of granulomatosis diseases could be. Let's look at Crohn's disease. Now, this is an inflammatory bowel disease of unknown etiology. Primarily, the patient has gastrointestinal symptoms ranging from abdominal pain, variable constipation or diarrhea, and sometimes obstruction and malabsorption. Now, treatment primarily controls symptoms, but it's not curative, and dietary adjustments, corticosteroids, antibiotics, uh, sulfasalazine, mesalazine, immunosuppressants, and tumor necrosis factors, alpha blockers like just the one which we've, the example given like infliximab are used. So this picture here shows you the endoscopic findings of the intestine, where you can see a lot of inflammation and raised granulomatous areas. The oral manifestations, the signs and symptoms are same as those seen in orofacial granulomatosis. There is diffuse swelling of lips and cheeks, edematous and hyperplastic thickening of the buccolabial mucosa together with fissuring, producing a cobblestone-like appearance. They are aphthous-like ulcers or linear fissure-like ulcers involving part of the mucosa. Glossitis can be seen, which is secondary to deficiency or malabsorption of iron, vitamin B12 or folic acid, which again leads to anemia. So these are pictures of how Crohn's disease can manifest in the oral maxillofacial region. You can see here edema or swelling, diffuse swellings of the buccal mucosa, the lower lip, as well as the gingiva, which if put together should give you the suspicion of an underlying pathology. So the clinical implication of this would be the oral lesions can be a presenting symptom of the disease and precede gastrointestinal symptoms by a long period. So here the role of a dentist is very, very crucial in identifying and catching these lesions early. So when the oral disease is caught early, it is much more likely to progress to bowel disease in children than when an adult is diagnosed. So it's important that the symptoms are caught early and treatment is initiated early. So oral lesions may lessen in severity with the treatment of systemic disease as well. Aggressive treatment is merited in the early stages to prevent fibrosis and premature disfigurement. That's something very important to be taken note here. And literally the same drugs are used for both the bowel disease as well as, of course, combined with steroid injection of a swollen mucosa to reduce the edema locally. Along with Crohn's disease, it's important to even understand Wegener's granulomatosis. Again, very rare but potentially lethal and uncommon systemic vasculitis with a predilection to present in the nose and the sinuses. And there is oral manifestation as well. The oral manifestation shows proliferative gingivitis, and this is specifically nicknamed as the strawberry gingiva, which you can see from the appearance of the gingiva in the pictures here. There is tooth mobility, diffuse ulcerative stomatitis, and also non-healing sockets. When the nose and the sinus tract sinus are infected or are affected, sorry, the granulomatous inflammation with discharge is typically the first sign. Untreated, necrosis will destroy the nasal septum, producing a saddle nose deformity and may perforate the palate, appearing as a large ulcer. So the picture here shows a large ulcer caused by vaginal granulomatosis, and the deformity of the nose is definitely due to vaginal granulomatosis can lead to midfacial defects. So signs and symptoms are very similar to a lymphoma, sometimes even a T-cell lymphoma. The management would involve biopsy, first of all, and also steroids and immune suppressive drugs, and definitely long-term follow-up for these cases. So to sum it all up, this is a very interesting flow chart that I have taken from Carson's Essentials of Oral Pathology and Oral Medicine, where they have discussed the causes and treatment of diffuse swelling of the lips and the mucosa. Now, it's important to understand that if you're having a patient who's come to you with the diffuse swelling of lip or the cheek, right on top of the this big flow chart here, is usually due to periapical abscess. Generally, the oral dental causes have to be ruled out first. Right, so apical periodontitis, periodontal abscess, pericoronitis has to be ruled out. If yes, then you know what you're looking at. You're already looking at, a detectable abscess, pus draining cellulitis, and then you would treat the patient accordingly with or without culture and antibiotics or drainage and then local treatment. Now the issue comes when it is not because of a known dental cause. So when it is not because of a known dental cause, you have other things that you need to consider. So then you need to branch out into looking at, was it only one episode, a single episode that it has happened, that this sort of a swelling of lips, cheek and face has happened? Then it's important to consider trauma, edema, hematoma, or an insect bite, right? So, but if it is an initial soft and recurrent swelling, very important, recurrent, that means the patient has had repeated episodes of a similar kind of swelling of lip, cheek, or face, or whether it's firm and persistent and long standing, then it's important that you have to take a biopsy. When you take a biopsy and it shows non-caseating granulomas, there you have it. You're already, based on the symptoms and your association with other systemic manifestations, you're either going to narrow it down to Crohn's, sarcoidosis, or Melkinson-Rosenthal syndrome, or simply an orofacial granulomatosis, which is a manifestation of any of these diseases. So then if you're having this in hand, you're already looking at treating the bowel disease, systemic disease, and definitely involvement of a physician at this point, and then managing the case thereon. But if the recurrent edema like swelling, and then the patient has been normal between the attacks and not long-standing disease, and if the person is having a history of allergy or atopy or possible allergen has been identified, then there are two possibilities. If you have an allergen identified, yes, and then you're looking at hypersensitivity reaction, and you would manage the case with adrenaline, looking at it as a hypersensitivity reaction. If you have not been able to identify an allergen, then you're looking at an angioedema, and again, your treatment, you need to take into consideration the treatment of one particular episode and then probably following up the case. So I thought this was a very nice way to sum it all up. It looks complicated, but then the way it has been put out, this flowchart should allow anyone who is having a case, or comes across a case with diffuse swelling of lip or the cheek of or the face. It is important to categorize the based on etiology and clinical presentation into which group that this patient comes into. So these are all the questions that should essentially pop up in your mind as soon as you see the case, and then you would be able to answer OSCE or OSPE or even any of the your modified essay questions more successfully. So that's it from me. I hope I have done justice to this chapter by explaining to you the most commonly how orofacial granulomatosis can manifest and the other miscellaneous conditions. And that's the reason why now you understand, because they cannot be grouped into one particular lesion. That's why they're called as miscellaneous disorders, and have been scattered across the textbook in various different chapters. So you can go through the textbook for more information regarding this. And that's it from me. Thank you. Should you have any more doubts, please feel free to contact me. That's all from my side.